Welcome. Welcome to Move to Learn, the Handspring webinar for manual and movement therapists. I'm Elizabeth Larkham. It's Monday, June 19th, and today we welcome Maureen Mason, the author of Pelvic Rehabilitation. Dr. Maureen Mason is an integrative physical therapist with a holistic practice. Her specialty certifications include Women's Health Specialist and the 900-hour medical training in professional yoga therapy. Maureen strives to optimize client health with the big wheel of mind, body, and spirit care. She offers clients meditation and mindfulness training with attention to the application of breath awareness throughout the day. She has a passion for helping women over the perinatal and menopausal transition times. Before Maureen informs us with her phenomenal understanding of this field, let's take a look at how things work. This presentation features copyright material from the book, Pelvic Rehabilitation. Please note this cannot be shared anywhere without permission from the publisher. The chat is on, so do say hello and tell us where you're joining from. This event includes readings from the book, guided embodiment experiences, discussion, and Q&A. We welcome your questions. Please submit these questions using the Q&A button on your screen. We aim to finish on the hour, but may continue for 10 minutes after the hour to ensure that Maureen can answer as many questions as time allows. The webinar is being recorded, and Handspring Singing Dragon will share a link to it in the follow-up email. We're also streaming live on YouTube, and we bring your attention to this medical disclaimer that this discussion is for informational and illustrative purposes only and is not meant to impart medical or therapeutic advice or instruction. Maureen Mason is the author of Pelvic Rehabilitation, a book just published in 2023, hot off the presses from Handspring Singing Dragon. Maureen is a specialist in interventions for male and female clients in pelvic self-care regarding bladder, bowel, gastrointestinal, pain management, and sexual health. Maureen Mason, welcome to Move to Learn. And here she is.
Hello to our global audience. This is such an exciting webinar to be able to share this information. And I thank all the team at Handspring and Singing Dragon for bringing it all together and supporting me. And in my book, when you read it, you'll see all the people that brought me to where I am right now as an expert in pelvic health and a mentor therapist. So there's so much about pelvic health that is helpful to know for your total health, whether you're working with clients or you're a medical professional or you have a pelvic health problem yourself you want info on. So at the end of this talk, you'll have some new insights on what pelvic health is, perhaps on your own body's processes, and maybe be able to provide care for someone that you love or expand in the medical field specialty. As a young physical therapist, I scrambled to find information on each one of these chapters, and each chapter represents at least 6 days of continuing education, reading, seminars, and things. So I always had to turn to the older therapists that were experts, call them up, text them, but many times I struggled alone too, because I was just too busy, and I had to try to figure it out myself. So the book, I had to look at the big picture. It's offering paradigms and potential programs and considerations. And now we know it's all connected. The pelvic muscle group, the bowl of the pelvis. Here's a pelvic model for you to look at. And it really looks like a butterfly. And in the best of situations, our pelvis can move freely in all directions. We can dance, we can jump, we can spin around, we can lie down and rest and be comfortable on our back in different positions. But we'll see as we go along today how the respiratory diaphragm, the upper throat, the larynx, our pressure systems from the throat, from the diaphragm into the pelvis. So they all have to work together. And sometimes it's that chronic cough or bearing down or a rib cage that's too stiff that's putting pressure down into the pelvis, or a rib cage that just won't, it's too wide and it's not moving up and down, the diaphragm moving up and down. So we have a lot of fascial aware providers on this webinar, and you know that everything's connected in the myofascial system. We have the bowl of the pelvis with the muscles on the inside, the deepest muscles, and then we also have, if we look at the back, muscles in the back with the tailbone coming down, the sacrum, the sacroiliac joints, the coccyx, and these are all elaborated in our first chapter. But suffice it to say, there's many layers here, and they all intersect with the abdominals, the latissimus, the lumbar, multifidus, and the pelvic floor muscles. So, all right, so now we'll move along and we'll look at some slides from each chapter. And then after we look at a few chapters, we'll participate in some movement practices that you can consider for your clients. Okay, so we're ready for that share now. Okay, so how do we get people to be aware of their pelvic floor? And some people can easily tighten certain private hidden body areas, the kegels or the pelvic floor muscles, but most people, they're just working automatically. An easy way to have some self-awareness is to lie on your side, drape your hand over your gluteals and just feel those glutes that move us around, and then move your hands closer to the midline of the body, and there, bingo, you're on the pelvic floor. So we can take a breath in this position and perhaps feel things relax. We can tighten like we're stopping a fart or gas. We can squeeze like we're stopping a urine flow. Sometimes you can feel a little lift there, but most people's pelvic floor doesn't move up and down very much. So this is the subtle, slight movement you might feel, okay? So this is side lying palpation. We see the hamstrings, we see the adductors, the inner thigh muscles, the glutes. And again, we're looking at a posterior view of where the pelvic floor is. I'll also introduce this to people in sitting, so they can just drape their hands under the buttock, under their sits bones, their ischial tuberosities, and try to feel, can they breathe and relax and feel anything letting go, moving, or can they exhale and tighten like they're stopping something, gas or urine, and see if there's any lift, okay? So this is one starting way to connect with the pelvic floor. Pelvic clock, or rocking and rolling around on our sitting bones, on the bony pelvis, is another way to connect with the pelvic floor. And here I just have a little outline drawn of our sitting bones, the ischial tuberosities, the base of the pelvis. Imagine a little bridge slung between those two bones. That's the pelvic floor. And the pelvic floor muscles are really a hammock from the pubic bone back to the sacrum, the tailbone inside, and then side to side inside of the ischium. So the pelvic floor, also when we tip sideways, it tightens a little bit and holds us if we're on an amusement park ride or driving a little too fast going around a turn. It's a postural muscle group, but it's also volitional. So we can be like, oh, I'm going to tighten if I'm going to cough or sneeze, that sort of thing. But the pelvic clock will go through a little movement exercise or rocking and rolling that might also help people with awareness of the pelvic muscles. And in child's pose, if we do movement practice and go into this, this is a way to just settle down, breathe, and perhaps connect with the pelvic floor and the breathing. So we'll go through this in a movement practice. This can also be a good position to notice, are the ribs moving at all? If you're a manual therapist, you can place your hands anywhere along that wonderful rib cage and facilitate a little bit of breath moving into the posterior, lateral, and basal lungs. And this rib mobility can help our digestion and our vitality. And then there's so many ways of drawing our knees up to our chest. We can pull one knee up, the other knee, we can pull our knees in the center. And then this happy baby where we have our knees up to the side. Anyone that's had an infant, they see the infant spent so much time up and down with the legs in this position. But if we just hold in this position and breathe, again, it's an opportunity to connect with what's happening with the belly, what's happening with the pelvic floor. And then we also have with pregnancy, on our chapter on pregnancy and early postpartum, we show many different exercises. Lying on your side, if you're pregnant and you're having pain, perhaps lying on your side and doing some exercises, which I demonstrate. The ultimate rehabilitation postpartum pregnancy would be to do some resisted rotation, maybe kettlebell workout, these sorts of things, or yoga or Pilates routine. And I'll bet most viewers haven't really seen a pregnant woman or a woman postpartum really saying, I need to work on my rotations. But rotations are finesse in our therapeutic analysis of how the body moves. And many times in pregnancy, we get that kind of penguin walk going, and postpartum, we'll see women just kind of locked up in the rib cage and not rotating. So there's a wonderful chart in the pregnancy chapter that goes through this. And I think what I'll do now is I'll give you an illustration of some of these movements that we've just shown. Okay? Yeah. Welcome to my San Diego yoga room here. Okay, so if we're introducing some of these movements to people, a nice thing to do if their shoulders and hips are comfortable, we can actually start in standing and have people just consider the bowl of the pelvis and how it moves, the bowl of the pelvis. And when we think of a butterfly, we can think of this sort of thing. Many of my patients with pelvic pain, it might take months to do this because they're just not connected to the body. So we might start with some more general, tuck the tail, round, 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 and then open, 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 shoulder blades back, these sorts of kind of primal body movements, okay? And then we might go to the mat work if shoulders and knees and hips are comfortable, and just begin, for example, with pediatrics. This can be a nice, safe thing for a child to do that's suffering with constipation or has been through trauma. Also, we could invite them, if they would like to put their hands on the blocks and just rock back and forth like they might see a kitty cat doing, or a dog, rock back and forth. And they could just explore that. Oftentimes without cueing, people will start to move in positions maybe that they need. And they may just go into positions that feel good for them. So we can call this cat cow, cat camel, partial press up, these sorts of things. But now the pelvis is moving. What I particularly like about this movement is we can rock back and relax the pelvic floor. And then we can go into child's pose from here. And this is a wonderful position to do manual therapy on the rib cage. And we can add, thread the needle, these sorts of things to really kind of unwind and see how is that rib cage moving? How's the rotation? And then many providers do use this rock and roll clock sort of thing, but it can be nice to say to someone, imagine you're sitting on a clock. 12 o'clock's your pubic bone, 6 o'clock's your tailbone, 3 o'clock's the right sitting bone, 9 o'clock the left. And people can throughout the day, maybe they're not attending to their bladder. They can do this a few times every hour and just kind of tune in what's going on down there. So they're prompting themselves to pay attention. And we can send a breath down there too. So those are some ways of using the movement practice. And again, someone can just sit on their pelvic floor and maybe feel, and people usually start laughing when you ask them to do this because it's the butt area, it's the private area, but we're talking fingertips right under here. Lots of times people will grab their glutes. Well, that's a glute. So we might cue them a little closer in, cough, tighten, or relax, and a breath down there. Okay. So those are some concepts for people to consider with cueing, trauma sensitive, that sort of thing. Okay. Very good. Then we'll go on with our slides now. So now we're in a chapter on postpartum happenings that can happen or through pregnancy. So in pregnancy, we can have a separation of the midline abdominal muscle. It's common and it can be kind of traumatic for women if they don't expect it, that they have a gap. And there's many protocols for working with diastasis. I helped outline a research study that was published. It's in the Journal of Women's Health Physical Therapy on a pilot study on postpartum diastasis rehab. We use kinesiotape and a light drawing in maneuver of the abdominals. Inhale, exhale, 20 to 30%, draw in lightly. We did that in 4 positions and we measured the gap. That's becoming old school because, so what if the gap is there? How are things functioning? And there's some providers that might say, I have the method, the method for diastasis rehab. Well, it's really about multiplanar movement. We have curl ups, we have diagonal curl ups, we have the quadruped series I just showed, going towards a plank, this sort of thing. We can do wall push-ups. And ultimately, we've got to be able to, with our abdominals and lumbar muscles, get up from the ground. If we're playing with a child on the ground or whatever we're doing, and move about. So this is showing what would be kind of developmental sequencing that we see toddlers do, or developmental neuromuscular sequencing, where be on all fours and then we'd shift and then to get up and reach. And this is with our lats into the abdominal and our hip pressure through the glute, triggering the abdominals to turn on in all different directions. So I put this in because I want people to think outside of the box. And if you're working with clients with diastasis, just look, is there a bulge or a doming? And if there is, doesn't mean it's catastrophic, just maybe the person putting too much load in and they need to dial it down and do something a little softer, okay? Because we don't want to aggravate that. And a diastasis rectus abdominis is not a hernia, but it can be described almost like a hernia, okay? And there's certainly support garments and things to help. Good. And then next, after diastasis, another postpartum item that can happen is pelvic girdle pain. So the pelvic girdle is a ring. We have the pubic bone in front, and then we have the sacroiliac joints on the right and the left and back. Also, we have the intersection of that whole bony pelvis with the lumbar. And many women, perhaps 10, 20, maybe even 30% develop pelvic girdle pain. If there's pain standing on one leg or that sort of thing, things are shifting. Women with this problem have pain turning over in bed. They might have significant pain stair climbing. So what do we do here? We find the best position to turn on the glutes, turn on the lumbar, turn on the pelvic floor, turn on the abdominals, and work on strengthening, controlling all of the muscle units that move around the pelvis. And the pregnancy is really a 10-month process. And so we have to consider patience, flow programming, and gradually ramping up demands. I went through this condition myself and I was lost. I had to figure out, and Pilates saved me, and pelvic stabilization exercises saved me. So, but it took over a year for me because I had also had athletic injuries, boom, falling on my tailbone, and a lumbar strain with my physical therapy care of my clients. So here we're simply showing a bridge, good old-fashioned bridging, but we're cueing the lats, we're cueing the abdominals and maybe the pelvic floor a little bit, and pushing out in a Pilates ring, activating the glutes, and the external rotators, snugs the femur back in the socket and works with the multifidus in the back to hold that back part stable. This may be an advanced exercise for someone with pelvic girdle pain. So again, there's many considerations that are addressed in the book on the topic, and you can look through that. This would not be the one exercise. There would probably be 8 different exercises someone would do with pelvic girdle pain, perhaps mini squats and other things. And then pelvic organ prolapse has its own shiny chapter. It's a big hidden topic. 30% of women experience it. And it's a little bit of a bulge that can happen where the bladder is lower postpartum, the uterus is lower, the bowel can be lower, and actually they recede in many individuals. They'll kind of go back up over time as estrogen function returns, as fitness returns, but some women suffer with the bulge. So pelvic organ prolapse has many helpful therapeutic options for care. And as a PT, I originally thought, I'm going to strengthen the heck out of that pelvic floor and thereby help. We have research from Scandinavia that shows, yeah, we can actually lift the pelvic floor in 8 months of rehab of 4 sessions a week with 40 or more contractions per day. That is a lot of strengthening. And for women to know, hey, do these 4 times a week, that can help. That can help some. Others really need more manual therapy. Here we're getting into the whole myofascial visceral network. If the uterus is a little bit stiff and low, and the bladder is a little stiff and low, those that are trained in osteopathic and manual work can do, per their medical license, internal and external work, manual therapy. And we have research out of the UK, Anna Crowle, Crowle, and she's referenced in the book, where she and her colleague had significant progress in reducing prolapse using biotensegrity, manual therapy by itself. Research has to study one topic. What does manual therapy do? Visceral biotensegrity work, where we're working all the fascial planes, helping with stiffness, gliding things up. So this is great to know about. And we can have a wheel of exercise, manual therapy, habit training, and I'll get into more of coming back to POP, pelvic organ prolapse, in some future chapters. So there's many different bladder conditions that can happen. Women tend to suffer more overactive bladder and urinary incontinence than men do, because men have their prostate. And I'm wondering if we can, Sandra, who's in charge of our slides, cut away. I want to show the male pelvic floor model here, okay? So men can certainly have pelvic floor dysfunction and problems. What I want to show you here is that guys have, this is a side view of the pelvic anatomy. We have an illustration in the book. We're looking at the amazing bladder, the prostate gland, the lower colon, and then the urethra is coming through here, okay? Males have the prostate gland, that is like a shutoff for the bladder. And it's an extra stop point that women don't have. Women are kind of looser in this junction here. However, men can have overactive bladder. When they're prostate, most men in their 40s, 50s, 60s, the prostate can swell a little bit. As that prostate swells, they can get the overactive bladder symptoms. Okay. Also, we have the whole intestinal area pressing down here. If we have GI distress, pressure down, the bladder is the last thing in the system, and that can make an overactive bladder, constipation or IBS, and we'll get to that. But I wanted to show that. And there's a very thin line here showing the pelvic floor muscles, and the pelvic floor muscles are really a lot thinner than we might think. So if we look at this model here, pelvis, front view of the urogenital triangle, and then we have an anal triangle, there's the urethra is hidden right up in the center. And women actually are unable to see that because it's hidden inside the labia minora and then majora. But this ischiocavernosus muscle here is very important for bladder control, because if we can learn to do a quick flick, for example, before we cough or sneeze, it's tensioning right here, and the urethra has a little sphincter on it too. So this is hard to learn to do to activate the front wall. Basically, people, when they try to activate pelvic floor, they tend to activate the back parts more so, okay? So I wanted to point out the anatomical considerations. And with an overactive bladder, we have, for example, the bladder sitting right on top of the uterus in the female. The bladder sitting right on top of the uterus. And so anything going on with her, with the uterus, which looks like a little bird here, that can pressure on the bladder too, okay? So if we go back to the slide, please, and thank you, Sandra, on the showing the overactive bladder, and it's showing that all of a sudden people can get an urge and feel a bladder contraction and leak. That's urge incontinence. And then we can also have stress incontinence when we cough or sneeze. And there, the intra-abdominal pressure overrides the pressure of the support mechanisms. So if we look at the slide from the chapter on bladder control, this is one of the main things that can happen. And we'll see little kids do this, grown women do this. I'll pose a question to the audience. Will tightening my adductor muscles help me not pee myself? Probably not. Sometimes it might help by a co-contraction, kind of involuntary, of the pelvic floor. The adductors do work with the pelvic floor. But if we're just tightening our abdominals and our pelvic floor, or our abdominals and our thigh muscles, that might be insufficient. Again, we've got to get that ischiocavernosus muscle doing its quick flick. Okay? Very good. So there's so many strategies described in this chapter, and then we go on to this chapter of gastrointestinal health and colorectal physical therapy. And it turns out in my career, I found in doing my medical screening with my clients, many of them with urinary incontinence also had constipation or diarrhea or mixed IBS, where sometimes they were constipated, sometimes their stools were too loose, sometimes they were bloated. So there's many different conditions that can happen, and I do portray many lifestyle factors, paradigms, and programs that we can consider for the GI health. Here is the illustration of the colon massage, which really saves a lot of people that have chronic constipation by doing little circles. Now we're seeing the hands in the top picture here at the left lower. That's the final train tracks for the colon, is that left lower, kind of inside the left hip. And a lot of people, if they have constipation, that's where it sits. And I say to kids, it's like Tootsie Rolls move along the train tracks, and they get stuck before the final station. So we're feeling for Tootsie Rolls. We're going along. And we'll do a little movement practice on this in a minute and just demonstrate different ways we can do this. But we can actually do from the right, inside the right hip, or above the right iliac crest, above the right inguinal ligament. We can start on the right, move across, and then go down to the left. There's many different ways of doing this. I was usually having people do 10 repetitions, right, across, and left. Upright, across the center, down on the left. Give it some love. And sometimes people all of a sudden will say, excuse me, I'm going to go to the restroom. We are helping mobilize the colon, the large intestine, and the large intestine works when there's pressure and stretch on it. It stimulates it to be mobile and have its own contractions. Okay, so, and then we go on to the andropause and menopause, midlife to elder years here in this chapter on very important life transitions, similar to pregnancy. We have, for people that are midlife, can all of a sudden start having pelvic health problems. Women, when they go through menopause, when their estrogen's lower, the urethra can actually have some weakness. The pelvic floor can be weak. Estrogen helps the pelvic floor muscles. And we have a decline of estrogen, progesterone, and testosterone as we go through that menopause transition. Things that keep blood flowing to the pelvic floor help digestion, they help our mood, they help our nervous system. So any exercise gets a plus for pelvic health. In seniors, we see balance problems. We see postural slumping. If someone has chronic postural slumping, that can put pressure down on the pelvic floor. Ultimately, as we age, we want to be able to walk and stride and to balance on one leg. Here's an interesting fact. Sometimes if balance is off, it's a sign of a urinary tract infection. People may not know they have a urinary tract infection, but they may be dizzy. They may have some discomfort. They may start having fevers. So we always want to consider red flags in anyone with GI distress, bladder pain, fevers, this sort of thing. And my book is quite thorough in going over red flags when conservative care is not appropriate. And then if someone has a urinary tract infection and they're on antibiotics, life-saving. The antibiotics are life-saving. It prevents sepsis, total body spread of the bacteria. But we know that the gut microbiome is kind of washed out. The good guys go and the bad guys go. So the life-saving antibiotics can put anyone that's been through a surgery, such as a hip replacement, a knee replacement, bladder infections, it can make their digestion more difficult. They may have loose stools or constipation. So here comes the field of probiotics, and we really do not have good protocols at this point in time, and these are under the supervision of a healthcare provider in prescribing. And sometimes people take way too much of a probiotic to try to help themselves, and they have great distress. So do not run out and ever start a huge amount of probiotics. We know eating a lot of vegetables and breathing fully can help digestion too. So here I'm demonstrating standing on one leg and dancing, and using striding poles can really help people to activate their latissimus, transverse abdominis, and kind of get their swing going. So people that need some balance exercises, we don't want them trying to stand and do tree pose and flop around. We want them to feel secure and stable. So they might hold the kitchen sink and do some leg lifts and things like that. So what I'd like to do now is we'll show a few more movement practices for our audience and review some of these topics we've just gone through. And thank you for listening. I know I'm sharing a lot of information, but each chapter truly does not have a cookbook approach. And again, there could be red flags where people really, of course, need to see a medical provider and then work with a team with conservative care, the yoga therapist, Pilates, chiropractic, acupuncture, functional medicine. We want to promote a team approach. So what we've gone through rotations for postpartum rehab. And if we just dial it back down here, some of the prime exercises that people are already doing probably in movement practices are kind of this, hip hinge, mini squat. And of course, this is done in CrossFit, weightlifting, but it's also can be part of a yoga routine where we start in mountain, grounding, noticing feet, ankles, knees, and hips. And thank our pelvis for getting us around. And we can go into a soft chair pose. And here, if we're tipping our hips back, we're lengthening the hamstrings here. And we can do this wide. And we can do it in all different positions with the feet closer together or further apart for stability. Also, it's nice to activate the pelvic floor through the foot, closed chain, foot, knee, hip, with a little sideways motion too. So postpartum moms tend to do well learning to lift like this. The more they're doing this, back strains and this sort of thing, and they might pivot with one point on their back. Then if we look at diastasis rehab, I really like rollbacks with rotation, and those can just be started in sitting. And also we have Ujjayi breath or transverse abdominis activated, inhale, exhale. You want to observe the umbilicus, what's the belly button doing when people are doing some tightening, because a lot of times right at the end, the belly button will go down and they're pressing down into their abdomen. They may have no symptoms with that, but if we want to really help the load transfers work well, we want to have the pelvic floor lift a little bit and over engaging the abdominal. Sometimes we see that distension or doming can happen. So that's some info on a diastasis and turning on the pelvic floor a little bit and awareness with squat series. And then with pelvic girdle pain, I did suffer this. And what I had to do, I call it moving like a mermaid. I had to get into bed with no pivoting. And I had to go like this. And some people might have experienced back pain and had to do this. And then I was very uncomfortable lying on my back because my lumbar was in spasm. So I would have to sleep sometimes with a towel roll here. Now, most people can just pivot on one ischium and get out of bed like this. This is a lot of force on the SI joint, and it's unlocking sometimes. So that could cause significant sacroiliac pain. So again, we do this somewhat robotic log roll, and then push up, and then get up and down. And really, you want to look at how your patients or people coming into the movement studio are walking, and people that are walking like this, something's up. And maybe this is what someone does with pelvic girdle pain. They're not going to take the long stride. So you're seeing a really nice long stride and a push off is a sign of good health with the great toe working, the calf muscle working, and the glutes turning on. So one progression that we can go through with pelvic girdle pain, we can do an adductor squeeze. So we have the yoga block and we're doing an adductor squeeze. And then we show a bridging sequence with the Pilates ring, lightly pushing out. And that could just be up to here, and that might be it. And eventually we can do more pressure on the left, more pressure on the right, more pressure on the left, more on the right, this sort of thing. All of these things can help, but eventually you want the person upright and moving around. So using my yoga application, mountain, warming up with the chair pose. I really like to do the heel lift and have people just really get those deep gastrocnemius muscles working. And we can do a small warrior one. Sometimes a large warrior one is very uncomfortable where we're doing a hip flexor stretch. And again, this can be for pelvic girdle pain, a progression in rehab, but this is also applicable to many people with pelvic pain because they have tight hip flexors and sometimes weak glutes. So here we are. We can be in warrior one in yoga, hip flexor stretch. And then we can push off. You're not seeing, but I'm really pushing off into the floor, and that's activating my glutes. So I'll have people practice this, just that push off, and see how does one side do versus the other. Okay. And then ultimately with pelvic girdle pain, we want rotation and we want this dancing butterfly movement possible. And I have worked with women that have been unable to live upstairs in their house and had to stay downstairs for a year. And it was delightful to be able to have them walk the fitness walk with their child at elementary school and this sort of thing once they went through the whole rehab. So again, patience, and sometimes just 3 reps of an exercise and they're done, they'll cramp. Don't say, I can't help you, you need surgery. Sometimes these people just, everything's locking up. They're critically weak, maybe their thyroid's off. So there's a lot to consider, and more gentle exercises done more frequently, building up to sets of 15, sets of 30. These are programs that I've done that have helped. And then on the prolapse chapter, basically things that can help. Women can't go around all day tipping upside down, but certainly people can have relief a little bit sometimes with prolapse if they go into puppy pose. And here someone could do some exercise. They could activate their core, lift the tailbone, turn on multifidus, inhale, exhale, engage the pelvic floor. And then also sometimes with going into down dog, women with prolapse might feel a little shift internally. And then when they get up, that bulge sensation is gone. So sometimes doing some decompression exercises with pelvic organ prolapse can help to reduce the symptoms of the prolapse, which the main symptom is the bulge. And that's just good information to know about. Prolapse can be cumulative over several days of walking, heavy lifting, and then constipation is a big trigger for prolapse as well. And then now we can move on to some of the other slides as well here. So balance is fun. We have all the different balance exercises everybody knows about. And then we have the meditation chapter, which one psychologist that bought the book, who's working in the pelvic health field, educating other psychologists, the first chapter she read was meditation. And I do thank my friend, Dr. Pauline Lucas, for writing this chapter, and also J. Michelle Martin, who wrote the pregnancy chapter with me. Traditionally, we see meditation sitting upright, lifting through the crown, and that's not comfortable for everybody. Consider someone with pelvic pain. They could have some sensitization of their sciatic nerve or their pudendal nerve, which is the private nerve that goes to the genital, urogenital triangle, anal triangle. So seated meditation might be a no-no for some. And if we're very rigid and say, you must sit now in the yoga class, do not use blocks, these sorts of things, you might not be aware that someone's suffering with actually nerve sensitization. So I always promote a little more rest, reclining maybe 10 minutes, set a timer, get yourself comfortable. When the arms are out to the side, we're not likely to fall asleep. So this is conscious, alert, mindfulness, meditation that we're demonstrating here. And we want people to know meditation can be done in any position. And there's so many breathwork pranayama practices that are fun to teach. And so people can explore that. Then we can go on to the next slide. Thank you. So here we have a view of the anatomy, which is interesting because it's really quite similar in fetal development at 5 months of fetal development. We have complete differentiation of male and female anatomy. And this starts from a common bulb that looks similar, is really very undifferentiated in the first few months of pregnancy. But we can see a new analysis or model of the clitoris that researchers are finding in anatomy is more of this broader shaped bulb that is underneath of the labia, and then the clitoris itself. And then we have the crus, the anchors that go along the ischium. It's kind of under ischiocavernosus. And we have the same type of structure in the male with kind of the bulb, the testicular area, the anchors, and then the shaft. Obviously, yin and yang, everything's external on the male, and same amount of nerve endings in the female, kind of tucked inside there. So amazingly, this anatomy has not been studied much until the last few decades. So that's just information for people to be aware of embryological anatomy. So our final chapter wraps it all up. And with integrative medicine and pelvic health, we think about all the pillars of health. How's our sleep? How's our stress? How's our social life, our social community, web of support, or lack thereof? How is our nutrition? Are we lacking certain nutrients? Are we low in vitamin D? Are we not producing our hormones? Have we suffered a biological condition based on genetics that we're struggling with, a rare disease, this sort of thing? And research is now showing that our gut microbiome is the main player in our health in terms of producing our transmitters, our serotonin, our feel-good transmitter, and our brain. It's bidirectional, and a very healthy digestive system is anti-inflammatory. Our mood is better if we have all the nutrients that we need. We have good social support. So the gut microbiome, if it's off, if we've really had food poisoning, for example, we have leaky gut, we have irritable bowel syndrome, diarrhea, IBS-D, whatever we eat actually permeates through our whole body. We used to have this concept of the blood-brain barrier. Oh, don't worry what you eat or do. It's protected from the barrier, the blood-brain barrier. My dad was a neurosurgeon, and he would throw out this term, the blood-brain barrier. Now we know it's not there. This is why if you have food sensitivities, you might have brain fog right away if you eat something. So many people now in the modern world, our food is very complex, but for some wheat and for some dairy are not tolerated, and this can cause GI distress, and then brain fog, itchy skin, manifest in very many different ways. And if someone is really bloated, for example, it could cause pain in the pelvic floor. It can cause bladder urgency and frequency. If we're not making our transmitters and we're not repairing things, then the overall health of the pelvic floor can suffer. And eating a lot of vegetables, cooked vegetables, is one of the best programs for pelvic health. There's so many nutrition programs, and we always mention fluid and fiber, and it's really that simple. Sometimes if people have really shut down gut microbiome, low motility, constipation, with 1 stool output per week, if they take a lot of fiber, it may block them up even more. So we have to be judicious, work with healthcare providers in what type of fiber, what type of supplements. Some people need medications for these conditions, but I really want to highlight ideally our food abundance and options for healthy eating. And if you're someone that's struggling with some autoimmune conditions, we see with functional medicine, many of these are healed in part with optimum nutrition and helping the gut microbiome. And there's many resources in this chapter and throughout the book. And we look at the social determinants of health, clean air, clean water, access to good food. If our vitamin D level is off, we're in a climate with no sunshine and we have low D, the bladder and the urethra rely on vitamin D for their integrity. So if you have an overactive bladder, taking in a lot of citrus, stomach's upset, bladder's upset, and you're through menopause, there's all these different factors. So consider the gut microbiome, and we're all learning as a society, and then in the healthcare providing field too, in the medical field, what can we recommend to people and offer? And we just all have to stay tuned on the news on what new discoveries are coming here. Herbs and spices can be really beneficial for our health too, so I highlight those. And my overall tenet of the book is to consider resiliency, compassion-based care, and many pelvic health conditions that people suffer. It could be mild, quick fix, or they can really be severely challenged. Give yourself time, work with a team of providers, reach out. And the book, again, I developed as a comprehensive resource for people for their integrative healthcare. And I think the pelvic health and the Bristol stool scale, which is the poop chart, that's an indicator of your overall body health. So now we'll take some time for questions as we complete our hour here. And thank you all for listening to all of the conversations.
Maureen, thank you so much for this phenomenally succinct tour of through your book and through human health. Let's take a look at how to order the book now. The recently published book, Pelvic Rehabilitation by Maureen Mason, the Manual Therapy and Exercise Guide Across the Lifespan, is available now. You can get a 20% discount off the list price. And the code will expire on, this is the code of June 19th, and it will expire July 19th. So you have the month to order the book Pelvic Rehabilitation, and then take your learning further in more detail from what Maureen presented today. Maureen, a question about that I have for you regarding the evolution of your book and what you're noting to be the evolution or the trends of updates in pelvic rehabilitation. I understand from a previous conversation that you're writing your PhD, your dissertation, and then this book evolved from that medical degree you were getting into a book that's accessible for everyone. So would you talk about that evolution and about what you noticed that you could bring new to the field?
Right, so in the medical field, when we write an article or a chapter, we have to only reference evidence-based research, which is studying one topic, such as tape for diastasis rectus abdominis, and see the result. In the world of rehabilitation and healing, there's so many different components that we can use. And we can't do research on, for example, 4 different approaches that Maureen uses for prolapse. At this point, I can write up case reports. But what happened was I originally wrote the book in 2017 to 2019, only for medical providers, even though I thought, well, maybe some other people could read it, but it was too dense. And the scientific journal articles can be very boring to read and too deep. So I had to release wonderful Dr. Lori Tuttle, researcher who was guiding my editing for the scientific journals. And I got my doctorate from Arcadia University in 2018. And I was training myself to write only scientific. So I had to release that and just go to, I'm talking to a urology nurse that wants to do yoga with her patients too. I'm talking to a chiropractor who may have some patients with prolapse, and she's working on pressure management, and she's doing developmental neuromuscular sequencing. So I had to take a broad view and use my insight and therapeutic knowledge of what could work to portray those as programs. And it's really exciting because we have medical specialties that treat these pelvic conditions, but many times one's not looking at the other. For example, constipation and bladder problems. Perhaps some urologists aren't screening what the GI is doing, and these sorts of things. So we want everyone to work together and look at how the whole pelvis is really a pressure system in a bowl that's influenced by so many things. Okay, so that was really exciting, and I had to make every important consideration count. And then I have a website, centralstationwell.com, where I have a blog with some constellation updates and things here. And then starting in September, I'll have courses online for movement therapists, as well as healthcare providers. And I already have some information up for the general public on that site, because I want to demystify and empower global health in this underserved population.
So many will be helped and will be appreciated by the depth of your knowledge and your explorations. It seems like a lifetime of work for you, a really dedication.
Yes, it has been. And originally I was asked to take a course on urinary incontinence, and I really wasn't interested, because I thought, pregnant women were kind of messy coming in with the kids and all these problems. And once I went through it myself, I thought that woman's a hero for making it in, or a wounded warrior that comes in that, admits to pain in the testicle and the low back pain and the groin pain, and begins to explore all these movement practices and options. Yeah.
Let's take a look at how people can get in touch with you, and take a look at your social media listings, and also information about your website. We have a couple of slides here on how to contact Maureen. The email is admin@centralstationpt.blog. And you could take a screenshot of this. Here's her web address, where you can get a sample chapter of the book, and how to contact Maureen on Facebook, on LinkedIn, and on Instagram also. Maureen, a question that I have is from your studies. How do you note that the approach to pelvic rehabilitation has been influenced by or inspired by the recent research from the fascia world, or even in courses that take the standpoint of applied biotensegrity?
So the research, thank you for that. The research that just came out of the UK that was published in the Journal of Women's Health Physical Therapy is a case series. It's a medical study. And we see that Anna Crowell actually did pelvic floor distress inventory analysis. And her approach using that one visceral myofascial system had significant positive benefits. So Some research is starting to come out. It takes tremendous work for a healthcare provider after they've done all their clinical work and charting to do all this research, but it is a passion. And then when we see people with complex problems that get better, for example, the hamstring muscle goes up to the ischial tuberosity and it blends into the sacrotuberous ligament and into the pelvic floor. When we see people that have had isolated pelvic floor therapy and they're not better, and we realize, oh, they have a strain in their hamstring and they're pronated. So the proof's in the pudding, so to speak. The providers that are more the mentor therapists and experts. For example, I lead rounds now at the clinic I used to work at, case solving analysis with the therapist. We see what works, and sometimes we really have to think broadly, and more research is needed. We learn anatomy in isolated chunks in therapy school for the most part, but the fascia is amazing and it's resilient. And we know that the genitofemoral nerve that comes down from the trunk goes down into the mons or the testicle. And sometimes people will have had, many therapies right around, for example, the testicle area, and no one's looked at their abdominal wall. So doctors are learning, therapists are learning, movement therapists can really get people embodied with trauma. Sometimes people, they've been through a lot and they're not in their body and listening to cues. So we have research that's showing that trauma-informed care and practices are therapeutic for people too. And there's many books out through Handspring and Singing Dragon that are embracing these paradigms and showing how things work. So we have to think perhaps beyond our discipline, for me, medical, scientific, evidence-based, and look what the fascial world and the fascial hub and all these webinars can offer us. Really exciting. If that makes sense, answering your question in a long about way. Yeah.
Absolutely. Maureen, thank you so much. It's such a pleasure to hear from you. And I know there's much, much more to come. When do your courses start?
In September, I'll have some launches and I'm just going to continue them. And there will be information on each chapter specific, because a lot of people fall through the cracks here and a lot of people suffer. So compassionate care, integrative care, there's a bunch of kind of nuts and bolts that are part of it that we just want to promote and consider.
Wonderful. Let's take a look now at the slide for the next webinar. We'll celebrate the summer solstice and then enjoy summer and get together again. We'll reconvene on Monday, September 18th, where we'll meet Lori Nemitz, who's the author of the recently published book, The Myofascial System in Form and Movement. And Maureen gave a great launch to that in her recent discussion. So thank you all. Thank you, Maureen, and thank you, Handspring. We'll look forward to being with you the next time. Bye now.